Okay, so now we're going to talk about part two, the cardiovascular system. What I want to start with, congenital heart disease, congenital heart defects. Those are kind of used interchangeably. Congenital heart disease is the outcome of a congenital heart defect. One of the complications of congenital heart disease or a congenital heart defect can be CHF. So before we even start, I want to talk about the signs and symptoms of heart failure, congestive heart failure, because that's what you're going to be looking for in every one of these defects as far as your assessment. Okay, a complication of congenital heart disease, heart failure. All right, so when you see these kids, they are possibly going to be edematous. They can have adventitious lung sounds. You can hear crackles. You have fluid on the lungs. Pulmonary edema is a complication. Increased weight, decreased oxygen saturation, increased heart rate, increased respiratory rate. They can be poor feeders. They can get sweaty when they feed. They're irritable. Failure to thrive is a comorbidity of congenital heart disease. You see the kids, like I said, that grow linear. They get taller, but they don't ever gain weight. That's as a result of poor feeding. They just get too fatigued and they can't eat. Some differences in blood pressure you may see in upper extremities and lower extremities. That's what's really important to take blood pressures in both upper and lower extremities. You can see increased heart size on an x-ray. Cyanosis, of course, circumoral cyanosis. You can see decreased pulses in these kids. So real important to check all of your four extremities for pulses. So those are all signs and symptoms of heart failure. In each one of these, that's what you're going to be assessing for. Okay, so that's easy. You're going to look for the same thing in all of these defects. Now, there are things that are specific to specific defects, and we'll talk about those as we get to them. But as a general rule, those are the things that you're assessing for when you talk about heart failure, congenital heart disease, etc. Okay, so now going through all that, what do I want you to know about each one of these defects? Okay, so basically what I want you to know is the defect, some of the pathophysiology, what it is and what it means. I want you to know what we assess for, if there's anything specifically that we look for related to this particular defect. And then I want you to know how we fix it or how we treat it. Now, there are some defects like a tetralogy of Fallot that has multiple step surgeries to fix, to repair. You don't need to know each one of those surgical procedure names. Just know that surgery is how we're going to repair it. Okay, we could go very deep into all of these defects, but coming right out of nursing school, unless you're going to be a pediatric cardiology RN, a general 30,000 feet view is what you need. Okay, so now we can get started. Congenital heart disease. About 1% babies born in the U.S. have some sort of congenital heart defect. More common in preemies and some of the chromosomal disorders. You'll have cardiac defects associated with them. Now, sometimes there can be more than one cardiac defect in a syndrome. Sometimes we're thankful that there's more than one cardiac defect because one cardiac defect depends on the presence of another cardiac defect in order for the baby to live. So, and I'll explain that a little bit more when we get down to where it actually comes into play. Pathophysiology of CHD in general is unknown. It could be genetic. It could be exposure to some sort of toxin or infection when mom was pregnant. So sometimes we just don't know. We talked about fetal circulation in part 1. So it's really important to know fetal circulation and what happens when that baby takes that first breath in order to understand these different defects. So I would go back and review that if you didn't get it the first time. Okay, so there used to be classifications of cardiac defects, acyanotic and cyanotic. We don't use those terms anymore. They use these 4 groups or classes to describe cardiac defects. Disorders with decreased pulmonary blood flow, disorders with increased pulmonary blood flow, obstructive, and then mixed. So when you talk about acyanotic defects, those are the ones with increased pulmonary blood flow. Most everything else is cyanotic. We're not gonna use those terms, but you'll see several resources, including some of the ones that I have up on the Pinterest page that talk about acyanotic and cyanotic defects. That's just how they correlate. You can remember the acyanotic ones go with pulmonary blood flow. Everything else goes in the cyanotic category. But again, this is how we're going to go over them. Okay, the first one we're going to talk about is tetralogy of Fallot. Now, tetralogy of Fallot has 4 different defects. It has a BSD, pulmonary stenosis, an overriding aorta, and right ventricular hypertrophy. Okay, so those are the 4 defects, sub-defects, that are part of a tetralogy of Fallot. Okay, they usually result in poorly oxygenated blood, so this is a cyanotic. You see cyanosis with this. You'll see all of the things that we talked about as part of the heart failure assessment. You can see definitely failure to thrive. One thing that is very specific to a TET is patients will try to normalize the pressure in their thoracic cavity. So what they will do is they will squat, or they'll pull their knees up. It's just the body's compensatory mechanism to try to increase that pressure. So that's one of the things that you want to ask parents when you're doing a good assessment is, have you ever noticed your child doing this? But if they offer that up, then you think, that could be what we're talking about. Okay, so I'll let you read through the pathophysiology there. Again, what I want you to know, pathophysiology, what they're going to look like, and how we're going to fix it. And this gives you the surgical procedure to fix it. Again, don't need to know the names of all of those surgical procedures. Just know that we're going to do surgery to fix it. Okay. This chart, I'll try to remember to come back to this chart. This chart does give you those defects that are corrected by surgery. And some of them, I'm not going to get off track. So let's just go with tricuspid atresia next. All right, here's some things to look for again with the tetralogy of Fallot. Tricuspid atresia. Tricuspid atresia is the failure of that valve between the right atrium and the right ventricle. The tricuspid valve is not there, doesn't develop. Okay, so there's no way for the blood to get from the right atrium to the right ventricle and then to the pulmonary artery. So again, you're going to see the same things. You're going to see a very cyanotic baby. You're going to see low oxygen saturations. You're going to see poor feeding, sweating, and these are fixed pretty quickly with surgery. Some labs and diagnostic testing. Anytime that they're considering a cardiac defect, you're probably going to see an echo, and it tells us structure. So we're going to be able to see structure and blood flow with an echocardiogram. All right, some disorders with increased pulmonary blood flow. Now, these are the more common ones, okay? This includes ASD, VSD, AV canal, and PDA. I think VSD is the most common by far, and then a PDA is probably the second most common. So with an ASD and with a VSD, these are going to be the acyanotic defects. So your oxygen saturations will be okay. They may be a little bit low. with the ASD is an atrial septal defect. A lot of times these are very small and go undetected. Same way with the VSD. They can go undetected unless they're pretty large or unless they don't close by about age 3. You usually hear a murmur with them. You can have, as an outcome, if it's severe enough, pulmonary hypertension. There are 3 different kinds or classifications of an ASD. You don't need to know those. You do need to know that it's an opening between the atrium that allows increased blood flow to the lungs. Most kids are asymptomatic. If it's big enough, you're going to see signs and symptoms of heart failure, which we have talked about already. How do they fix it? Well, they just kind of wait and watch. Usually close about 18 months. Get down to this part. 2 years, sorry. That's VSD. It's 18 months with an ASD. You don't need to be that specific. Just know that they a lot of times close spontaneously unless they are large, or if they stay open longer than 3 years, then they need to go in and close them surgically. All right, a VSD is very similar to an ASD. It is the most common congenital heart disease defect. Spontaneous closure usually happens by about 2 years. If it's large enough or if it does not close, then they have to go in and do surgery. Now, when I say surgery to close the septal defects, a lot of times they can do this with a cardiac cath, and they go in and they kind of put a patch on that open area between the atrium or between the septum, between the ventricle. So that is a new advancement that they can do it with a cardiac cath. All right, here's the pathophysiology behind that. Some complications, you can get pulmonary hypertension. Again, heart failure is always a complication. It does increase your incidence of infective endocarditis as well. All right, so AV canal defect. AV canal is closely associated with Down syndrome, and a lot of times they have another defect as well. So it is, get to my notes here. So basically there's a big hole in the center of the heart, okay, and instead of a separate tricuspid and mitral valve, they have one big valve. So that affects blood flow through the heart. Permits oxygenated blood from the lungs to enter the left atrium and the ventricle. So oxygen saturation can be affected a tiny bit. It produces a left to right shunt, as do the VSD and the ASD. Some complications: pulmonary edema, again, pulmonary hypertension, heart failure. It can be partial or it can be complete. Complete, of course, has to be repaired surgically. All right, and a PDA is failure of that ductus arteriosus, which is present at birth and all during fetal development. It doesn't close, okay? Now, some of the defects, like I said, we want that PDA to stay open. So they'll use prostaglandins to keep it open in order for the baby to have some sort of oxygenated blood. In other cases, when they want it to close, then they'll use indomethacin. All right, what can I tell you about a PDA? It is the second most common defect. Usually the PDA, or the ductus arteriosus, closes within the first few weeks of life. But if it doesn't, then it's called a patent ductus arteriosus. Okay, so there's the pathophysiology. Again, what you're gonna look for? You're gonna look for all the signs and symptoms of CHF. Patients getting tired, tachycardia, tachypnea, those bounding pulses. How do they fix this? They fix it with indomethacin. What else can you see? A lot of times the blood pressure is decreased with PDA patients. Respiratory rates increased. I'm trying to think if there's anything that it doesn't mention in the book. If they go in and try, or if they use indomethacin and try to close it and it doesn't work, they can also use a cardiac cath. And I don't know if it listed this about cardiac cath in the text, but they can go in with a cardiac cath and put it like a coil in there to close that patent ductus arteriosus. All right, so another group is the obstructive disorders, okay? And the obstructive disorders are just what they sound like. Something's obstructing the blood flow. We're going to talk about coarc, which is coarctation of the aorta, aortic stenosis. So if you just think about those words, you can figure out what that is. And then pulmonic stenosis, same thing. Stenosis means narrowing. All right, so a coarctation of the aorta. This picture is really good. It just shows that tight little space, that narrowed part of the aorta. And you know the aorta is where all your blood comes from. So it affects the circulation, forces the heart to pump harder to get blood to the rest of the body. So you've got a restriction. You've got a clog in the pipe. This is where your blood pressures are going to come into play. You need to make sure that you take blood pressures in all four extremities if you suspect this, because what you're going to see an increase in blood pressure in the upper extremities, and lower extremities are going to have, the lower extremities are going to have a lower blood pressure. These kids, sometimes this goes unnoticed, and these kids present with like leg pain, or decreased pulses in the leg, or poor circulation in the leg. They can faint, they can be dizzy. Definitely going to hear a murmur with this. And the repair usually is done by age 9 or 10, and it's surgical in nature. So they go in and they actually kind of balloon up, and again, they can do this with a cardiac cath as well. They can go in and balloon that aorta to widen that area. Now, these kids usually present, like I said, with high blood pressure in the upper extremities, so you have to think about aortic rupture, aortic aneurysm, etc. So those are some things to look for. With an aortic aneurysm, I don't know, sometimes you can hear like a bruit. I've never heard one, but with an abdominal aortic aneurysm, you can hear like a whoosh, whoosh, whoosh over the abdomen. So there may be some differences in heart sounds other than just a murmur with coarctation. I'll have to look that up. Write that down. All right, how are we going to find this? Usually a chest x-ray may just show an enlarged heart, and then they may do an echo to see what they could see. Aortic stenosis is just what it sounds like. Okay, it is a narrowing of the aorta. It can cause left-sided heart failure, all of those signs and symptoms of congestive heart failure that we talked about, edema, etc. Kids sometimes with aortic stenosis, we don't know it. It's very asymptomatic. Causes decreased cardiac output. Left ventricle becomes very hypertrophied. Okay. Pulmonary edema might develop. You definitely hear a murmur. These are diagnosed with an echo. These are the kids that come in with chest pain, and on an EKG you see some sort of rhythm disturbance or some sort of, what am I trying to say? Conduction deficit. They do an echo and then they find some aortic stenosis. Treatment, surgical repair, or they can use, again, the cardiac cath and put a little balloon in there and take care of that situation. All right, the next one we're going to talk about is pulmonary stenosis. And it is, the pulmonary valve is narrow, okay? So your blood is the restriction is from the right ventricle to the pulmonary artery. You might see signs and symptoms of mild heart failure. You're going to see some cyanosis. You're also going to hear a click with S2, with pulmonary stenosis. Treatment is usually surgical. They can again use the balloon to go in and enlarge that valve, or enlarge that stenosed area. All right, mixed defects. Transposition. Okay, transposition is just what it sounds like. The positions of the aorta and the pulmonary artery are reversed. The aorta comes off the right ventricle and the pulmonary artery comes off the left ventricle. So that's a big problem. Whenever, this is another one where you want that patent ductus, or you want that ductus to stay open. As the ductus closes, then the symptoms get worse. So these guys may get a dose of the prostaglandin, and then they have to go in and fix that pretty darn quick. So surgery is done by 4 to 7 days. Usually these guys, if they're going to show symptoms of congestive heart failure, it's pretty darn quick. These are the ones that just don't feed well, that have a low O2 sat. So these guys don't have time to develop those true signs and symptoms of congestive heart failure, like edema, or, well, they may still have some pulmonary issues like adventitious lung sounds, but they're going to have altered vital signs, increased respiratory rate, sweating, etc. when they feed. All right, total anomalous pulmonary venous connection. Ugh, that's a mouthful. This one is not a good thing. It's really incompatible with life unless something else is going on with it. This is where, again, you want to have a patent foramen ovale or an ASD in order to just get a little bit of oxygenated blood to the rest of the body. And this has to be fixed pretty quick. You're going to see cyanosis. You're going to see poor feeding. It's going to be pretty obvious. Okay, and again, surgery is how we're going to fix this. Truncus arteriosus. It is a mixed defect. This is pretty rare as well. It's only one major artery leaves the heart. Okay, less than 1% of all congenital heart defects, and it affects males more than females. This is, again, one that surgery is going to have to be performed pretty quick, and they may have to have more than one surgery. What they do is they put in a conduit, and that does not grow with the child, so they have to go in and revise that. It's kind of like the old AV shunt surgery, where they put one size in and the kid grows and they have to go put another size in. So this may be multiple surgeries. An echo is going to show that. That's how we're going to confirm that. And again, with some of these defects, you also have an ASD and a VSD. That's probably why the VSD is the most common, is because it can occur with in conjunction with a lot of these other defects. All right, hypoplastic left heart. Hypoplastic left heart is where everything on the left side of the heart is really underdeveloped. Okay, so we know that in a normal heart, the left side of the heart is the one that does most of the work. Well, with hypoplast or hypoplastic left heart, it's the right side. So this guy, okay, really there's about 3 different things you can do for treatment. You can do palliative care if the defect is so bad that repairing it's not an option. Heart transplant, pretty darn quick. Or if it's not too severe, they can do like a staged surgery beginning pretty quickly after birth. Okay, Again, with this one, if you have a patent ductus, then your baby may not seem like there's anything going on until that patent ductus starts to close. Then you have stenosis appear, and they go downhill pretty quick once that patent ductus closes. So these guys might get some prostaglandin to keep that open. You're going to see all the same signs of congestive heart failure. You're going to see tachypnea, tachycardia. With this one, you might see some hypothermia, low pulse ox. You might hear an S4. When we talked about normal heart sounds, an S4 almost always means that there's some sort of cardiac something going on. Okay, so that's all the defects, and that's as far in depth as I want you to go, okay? Just kind of know what they are, know what they look like, and know what we're going to do to fix them or treat them. So, going back to the general term of congenital heart disease, what are we going to do for all of these kids in general? Well, we're going to improve their oxygenation. There are certain defects that you don't give oxygen to, and those are the ones with increased pulmonary blood flow, okay? So the VSD, the ASD, the PDA, AV canal, okay? Increased pulmonary blood flow, oxygen is not going to help them. You can give them oxygen, but oxygen is not going to improve if they are low. So we're going to improve their oxygenation. Now, mom and dad need to be taught of ways to improve their oxygenation, proper positioning, making sure that you keep their, if they have a lot of mucus, get all of that out of there. Make sure that they know when to get concerned about their baby's breathing and oxygenation. Lots of teaching here. Some ways to relieve the hypercyanotic spells that go along with tetralogy of Fallot. Need chest positions, provide some supplemental oxygen, and morphine is going to help slow down their breathing. IV fluids, but you have to be very careful when you're doing IV fluids with cardiac kids because you might have some sort of CHF going on, heart failure, which pulmonary edema can be a part of, and you don't want to fluid overload these kids. So IV fluids in cardiac children is a slippery slope. Promoting adequate nutrition because, like I said, failure to thrive goes along with a lot of the cardiac defects because these kids just get so tired eating. So mom may need to feed more often, higher calorie formula, etc. And then assisting the child and the family to cope. This is a lot for parents to take, especially with a newborn. If they're discovered later on in life, then a lot of times it's a little easier for the family to cope with that. But when babies are born with cardiac defects, there are a lot of family dynamics that you have to address. So lots of teaching, lots of resources, reliable, reputable resources are good. Preventing infection. These kids, RSV prophylaxis, they're some of the ones that are going to need RSV prophylaxis. You don't need anything compromising their respiratory status. So these are the ones that will get the Synagis. Making sure that they get prophylaxis for infective endocarditis as needed if they're congenital heart babies and they have congenital or cardiac surgery. Then later in life, when they have dental procedures, they are absolutely going to need prophylactic antibiotics. All right, so this starts to talk about child undergoing cardiac surgery, and a lot of these kids will end up with cardiac surgeries. So I want you to read through this. Very important post-op care. Lots of bullet points listed there. So I would definitely know those. Some possible complications after cardiac surgery. I would definitely know those. And know that heart failure, even after cardiac surgery, could be a complication. All right. Some teaching guidelines for home care for the congenital heart disease patients. One of the things that I want you to focus on is parents often think that, oh my gosh, my baby's never going to be able to do anything. And a lot of times once these defects are repaired, these patients, I mean, they do well. So promoting normalcy, making sure that you stay on track with the child's development, those are all still really important with cardiac kids. We tend to think cardiac, and cardiac is probably the most serious situation. If you have a cardiac defect, then it's a pretty serious situation. So, but we tend to forget about the developmental portion and the family teaching and the, oh my gosh, my child's, you need to teach them that their child can participate, and they'll just have to take a few extra precautions here and there. But promoting normalcy, very, very, very important in that child. Okay, I think that is it for the cardiac defects and and heart failure. I think some of this content overlapped. That's not a bad thing. So that's about all I got.